get the tech to work. And like I said, it's super easy stuff tonight. We're just going to talk about the role of the EKG tech, where we're going to find EKG techs. And I mean, it's only 44 slides, so probably like 6, 30, probably. Listen, we can stay as late as I want. I don't feel like we're being shortchanged. Well, it is. I'd like to go home and see my wife. Got 4 kids. She's had enough. So some of the common terminology, you'll hear EKG or ECG. They just mean the same thing as electrocardiogram. The EKG is it's the K is from Latin. So this is just a visible form of the electrical movement of the heart, the electrical impulses of the heart. We're going to hook them up to a cardiac monitor. We're going to learn all these things. Hopefully next class I'll have a cardiac monitor to bring to show you what the leads and the cables and everything. Diagnosis, we technically don't diagnose anything. Paramedics don't either. I have a differential diagnosis when I'm in the field, but the diagnosis itself is by the physician. So the important role of the EKG tech is you're going to recognize some of these possible critical rhythms, and that way you can kind of like, hey man, you can quit right. So you'll be able to point out. And some of the ladies that's come through here, they work for cardiology offices. And as time goes on and you build a relationship with cardiologists, they'll actually ask you what your opinion is on this. But studies show like paramedics and EKG techs, they're probably better reading these than physicians. So, but they're going to make the diagnosis. A cardiologist is a physician, a doctor who specializes in heart issues. You might hear the term interventionist. I know for like McLeod's, they have cardiologists, but they have interventionist cardiology that actually puts wires and catheters into the arteries of the heart to place stents, do balloon angioplasty and stenting. And EKG techs, that's the person who comes into the room and says, hey, my name's Burley. I'm going to run this test on you real quick. Ambulatory just means that they're walking. So ambulatory care are people who can generally, they're not going to spend the night in the office. They're going to come in either by wheelchair or walking and then do their test and leave. That's an outpatient treatment. And then, of course, inpatient are ones that stay at the facility. And acute care just means these are people with short-term immediate care, illness, or injury. A myocardial infarction is just myo means muscle and cardial means heart. So that's your heart muscle, and an infarction is a blockage of an artery or a blockage, and that's commonly called a heart attack. And another, some other terms you might hear is an MI. That's just the initials, MI for myocardial infarction. So if you hear someone saying, you know, the patient in room 5 is having an MI, that's what they're referring to. Sometimes you'll hear them use the term acute coronary syndrome or ACS. That's very similar to myocardial infarction. So if you hear that, that's what it means. And then scope of practice is what you're allowed to do legally. So, for example, in your scope of practice will be, you know, interviewing the patient and obtaining a 12 lead. But it's not within your scope of practice to tell them like, hey, it looks like you have some AFib. You know what I mean? It's not that's outside your scope of practice. That's being the doctor. Where do we find these ambulatory care centers? Of course, these urgent cares, doctor's offices. There's a lot of cardiology specialty clinics. Like I know McLeod has one over at Sumter. So they got McLeod Cardiology hanging out over there. So yeah, you can find them just about in every little town, right? Well, maybe not 10. It's almost like 10. Yeah, I don't worry about that. The inpatient settings, these are ones that have staff that are there overnight. Hospitals, long-term specialty care centers, rehab centers, some of the, we used to call them, they're skilled nursing facilities, nursing homes. So those patients are just kind of like residents there. All right, so how would the day-to-day task of the EKG tech be different at different types of facilities? So what do you think, you know, you're talking like a doc in the box versus being at a level 1 trauma center, level 2 trauma center like the McLeod MSC is. What are some things you can think of? Off the top of my head, I think scheduling is probably a big one, right? Because if you're at one of these big facilities, they're probably working 12-hour shifts or something like that, or day shift and night shift. Where I know Dr. Lecker over at Sumter at Faster Care, they close at like 5 o'clock. You know what I mean? Yeah. I know a lot of the day-to-day stuff at those smaller cardiology offices, like the 2 ladies that were in the class with us, they form really close relationships with the cardiologist, and over time they earn a lot of trust with each other. But I would say at these bigger hospitals, you probably know the doctors, but you're going to be all over that hospital getting EKGs. So you might not have those closer relationships at these big hospitals like MUSC and the Big Mac. That's what we call it. They call it the Big Mac over there, for the Big Cloud Hospital. Well, if I say the Big Mac, that's what I'm talking about. Let's see, how would you consider the advantages and disadvantages of each one of these facilities? What do you think? Say again? So just what would you consider an advantage or a disadvantage when you're comparing like a Faster Care versus a Big Mac?
Sick bay got washed.
That's true. I like that. Yeah.
The hours.
Yeah, longer hours.
More responsibility.
I'll tell you that one of the biggest one that stands out for me is just from the coming in and out on the helicopter, as we call it the McLeod Mile. Whenever we land at that helipad, we have to take someone up to, like one of the critical care floors, ICU floors. We walk forever, right? It's like we're nonstop walking through McLeod. And I just can't imagine if I was an EKG tech there, right? Let's say I'm older now, like I turned 50 this year. If I had a hip problem or a knee problem, you know what I mean? That would probably be something I would be worried about working at McLeod, because they have some EKG techs that set it to a monitoring room. You know what I mean? They just watch the screen and document things, but they also have ones that have to walk that whole place all the time. So that could be an advantage if you're trying to get your sets in, or it could be a disadvantage if you have some type of work over on, right? Soft skills versus hard skills. I'll tell you, at least with EMS anyway, emergency medical services, a long time ago, you would hear people say, Paramedic Smith, I'm just making a name up. That guy over there, man, he's a drunk and he beats his wife and kids and he's got a DUI. He's a heck of a paramedic. And those dudes would stick around forever. Like they weren't allowed to drive ambulances, and they need to work on. Well, I'll tell you, things are different now. People get by better on soft skills. So being a good paramedic would be like a hard skill, right? The technical things, starting IVs, pushing drugs. But soft skills are things like showing the work on time, being prepared for your job, good attitude, smile on your face, just being good, nice to be around, right? No hassle, no drama. And what you see now, or what I've seen now in the last 20 years or so, is people with soft skills stick around forever. And the people with hard skills, they don't care, because they just don't want to be around people like that. So there's just two big differences between soft skills and hard skills. And what we really look for is people that have a combination of both. I like people that show up on time with a good attitude, that don't stink, you know what I mean? Like have good hygiene, that are nice to patients, that care about patients, and but they can also like start IVs, get EKGs. It's hard to find employees that meet both those check boxes. And when they do find them, they don't let go of them. You'll see some of these ladies, when you do your time over at McLeod, there's some older women of a certain age over there that have been there forever. And I'll be willing to bet they have both soft skills and hard skills. Prejudice, an unfavorable opinion of a person or group of people based on their race, religion, or so forth, without any bias. There's all kind of medical studies out there that show there's a lot of bias in medicine. That's my speakers. There's a lot of bias in medicine. one of the interesting ones I just listened to on a podcast had to do with pain management in pediatric patients. And the whole study overall showed that, for example, African-American, Black people, they are less likely to receive pain management in the pre-hospital setting, right? Regardless of, if you put the same amount of one stack of patients versus ethnicity, you will see white folks get a lot more pain management than Black folks. Mm-hmm. And the same thing goes with kids. Mm-hmm. There's a lot of racial bias baked into us in medicine, right? Even, have you ever heard of a pulse ox? Y'all done some different hospital stuff. So where you've probably seen it where they put the little red thing, they put a little probe on their finger, puts a red light through there, and it tells you the oxygen saturation of the blood. Mm-hmm. That device is FDA approved. You know how many Black people were in the study? That, well, now we found out, right? Because now we're looking at everything. That if you have darker pigmented skin, it actually gives you a few percentage points. It adds it. So it doesn't sound like a big deal, but back whenever COVID was a big deal, right? If you were less than 93%, they would give you oxygen, right? If you're less than 93, you got the oxygen. If you're greater than 93, they're like, there's nothing wrong with it. Well, let's say you have darker skin than me, you might be showing 95%, but actually you're less than 93%. Right. And you would be, that would factor out your hair, and it's just off the pigment of your skin. So what I like to do for myself is I try to factor in my own, even unconscious bias. And if I have a patient has pain, right, whatever, I factor that in. I'll go, you know what, I don't know, but I know that I'm less likely to give Black folks pain medication. So I make sure I'm aware of my biases. I try to be as aware as possible when I'm treating my patients. So just do that too. So it could be, I don't know, maybe you're speaking to someone who's Jehovah's Witnesses don't have anything with blood products, right? Or if you have a Muslim patient, they want to be handled by a person of the same religion. I'm cool with that, and I don't try to bust up in there with my values. Does that make sense? So one of the things I also do is if I'm making you nervous, right? First off, I try to get on their level and try to tell them like, hey, I'm here for you. I'm here to help you. But if I make them nervous, I find somebody else to take care of it, my partner or whatever. I do my best to try to factor that in. Hopefully that all makes sense. Having empathy for how someone else feels, their experience that they're having. One of the best examples I've seen of this is I had a paramedic student that was getting ready to start an IV on a patient, and they said, "This is the first IV I've ever started." But they said it to the patient. How do you think that's a lack of empathy? How do you think the patient feels, right? That was bad, right? Yeah. So just try to put yourself in someone else's shoes. A lot of times it's on the ambulance, we see them at their most vulnerable. Maybe they can't clean themselves, you know what I mean? Maybe they can't get out of bed, and just have empathy. And then a code of ethics, that's doing the right thing. What's morally right or wrong. Acceptance of constructive feedback. I'll tell you what, that one of the good things about my job at the Air Force Base is we do 100% peer review on every patient contact we have, which I do appreciate. It gets peer reviewed by another paramedic, and they'll write whatever their comments are on the QA. It's peer review /QA. The QA is the quality assurance. It's an open conversation between providers. And for example, my last shift I worked, we have a dental clinic that's part of the med group. And they called on the office phone and they said, hey, one of our staff members is feeling good. She collapsed. Can you guys come check her out? Well, we work with the military. The military guy says, no, you have to call 911. So you got to call 911. We can't just send the ambulance around. So anyway, I overheard this and I was like, hey, why can't we just go around? They're obviously concerned for one of our team members. So he goes, well, I told him I had to call 911. You do whatever you want. We loaded up and we drove around there. So when we showed up, myself and my partner, they said, oh, we decided not to call the ambulance because we didn't want to create all the commotion because the fire department shows up, the police department shows up, and it looks like a crime scene, right? You have all these emergency vehicles, the lights. I said, "No, man, we're just here to help." Anyway, the young lady had gastric bypass a couple months ago, and she's not feeling good, running a fever, and that could be anything, right? So, but the problem was she didn't want to go to me because they were rude to her to me. And she wanted to go to Lexington ER. Well, I can't do that without permission. So I asked case management, and they said no, you can't. So anyway, I told them, listen, these are all your options. I do recommend you go to the hospital. You know, if you can have someone drive you at least across the line, Richland County, there's 14 ambulances over there. If something happens over there, the other side of the river, just call 911, they'll come get you, take you wherever you want. So I did the report on that, and then that's what they ended up doing. The other paramedic said, you didn't get a refusal from the patient. And I said, well, so my response back was, thank you for the feedback. She didn't refuse my medical advice, she followed it. So I always start with that. Thank you for the feedback. So accept constructive feedback, and that I never take it personal. So, and a lot of times that just diffuses it. You say, thank you so much. I appreciate you bringing that to my attention. That's all you got to say. I don't engage with them. I don't get in arguments with people. I take it for what it is, and then I move on all that. That report will go to a doctor, our med control, and he'll read it, and he might have some feedback too. Yeah, you're right, or yeah, you're wrong. And I'm good with it either way. Had care for your personal appearance. I did shave for y'all today. I'll let you tell or not, put deodorant on. So I was very proud of myself. Yeah. Have attention to detail, good communication skills. Remember that, especially in these big facilities, for y'all are working in big places, that your nonverbal communication is what people see more than anything else. So if you're walking around, you know, all mad all day long, or at least mad looking, people might think you're in a bad mood, even if they don't interact with you. So just remember that your nonverbal skills are important. Accept cultural diversity. I love hearing about. I'll ask about people's, you know, if you're wearing a particular pattern of clothes or whatever. Food, give me a break. I'll eat all food. Just embrace it. It's great. Like I said, the diversity of knowledge is what makes it not only is a good class, but a good country. You know what I mean? The diversity of people. Without it, we're no good. And have compassion. These are just the qualities of good EKG tech. Good flexibility. You know, sometimes they ask you to stay late or work over. Try to be flexible as you can. On the other breath, they're going to tell you, you know, it's important you have work-life balance. So, you know, if you have a family, you also have to factor that in. Good initiative. I like to be in the self-starter. I like to be around self-starters. You know, if you see trash or something, it's good. Help out. You know, even if it's not your job, if I saw something over there, whatever. Y'all leave something behind. It's not a big deal. There. Here's a conversation starter. Can you think of any other soft skills that would benefit in EKG tech? I'm not ripping through these. I'm going too fast. Think of anything?
Willingness to help.
Yeah, like you said, just do whatever he does. You can deal with somebody elderly, maybe they need help.
I like that. That's a really good one. Yeah, man, I always try to, if I see someone struggling with the door, coming to the door, open the door. Like we all come in, hey, welcome. Trying to be nice to people. A lot of people don't want to be at the hospital. I get that. And I'm sure, I keep picking on you because you got the cloud shirt on. Some of the meanest people can be medical people. I don't get it. You know, I go more into Timmy nowadays than anywhere else. But I'm so mean over there about everything. I'm like, hey, I don't call my I didn't call. But I have a legal obligation to respond. And then I have to pretty much tell people I recommend you go to the hospital because if they die within 24 hours, I lose my ticket. So it's a weird position I'm in. And, you know, the ER is a revenue filter for that hospital. probably 70% of the admissions come through the ER. So they should be happy to see us because we're bringing them money. Let's see, what are some situations on the job that would require soft skills? Why would these skills be important in these moments? Can you think of a situation where you have to use a soft skill?
I'll look
Could be
at
the
that.
job. Yeah.
What we're gonna do is see if each week.
That's right. I know with my job, I get relieved. I work a 24-hour shift. I can't leave until my relief shows up. And sometimes they're late. You know, most of the time they're early, but sometimes they're late. Well, I don't ever show out. You know what I mean? Like, I might think it in my head. I got better places to be than hanging out here. And I hate running a late call or catching a late flight, but it is what it is. But I think that helps with the soft skill, because if I was to say something to say, Robert Weaver is one of the paramedics. If I was to jump on him about being late to work, what do you think he's going to do to me? Well, I can't. And life's going to happen there. I'm rarely ever late, but it could happen the next shift. I guess going with that, just being forgiving of other people. Give people the benefit of the doubt. Sometimes it's hard for me to do, is to first believe that they made an honest mistake. I try to tell myself that. This isn't personal. They made an honest mistake, and I try to forgive people. I do my best. Let's see. Remember these points about effective communication on the job. Good communication skills, they are verbal and nonverbal. We already talked about that. Body language, like words, communicate negative messages. One of the things I hate to see doctors do is this. Go, sir. I'm doing great, thank you. Listen, put that down and come learn some EKGs with us. I said, put that down and come hang out with us. Do some EKGs. Trying to get it together. So, this is one of the things I hate when doctors do. This right here, when they're talking to you. All right, yeah.
Yeah,
Okay.
yeah.
Yeah.
Oh, then you start walking around.
Yeah. Yeah, it's checking. Looking at the watch.
My husband had a doctor's appointment. He was taking off his coat, putting off something and walking out the door as while we were still having to ask him questions about my husband's bladder. He's like, all right, well, I'll,
Yeah.
I'm like, where am I at?
I've been over in that Tubi. We had a Tubi contract for about 10 years. So and I've been over there for about 30 years now with fire and EMS. So I know a lot of those people. Went through the Tubi Fellows program, and anyway, I'm as close friends as you could be with some of the physicians, you know what I mean, on a professional level. But whenever they give me a hard time, I'll say, "You make $300 an hour." That's the end of the argument. You're mad. You're making $300 an hour. I'm mad. I'm not getting nowhere near. So really, come on. Focus on the patients. Not you're upset about me breaking your patient. All right, let's see. Positive nonverbal. Stand up straight, arms relaxed. Listen to the speaker, make eye contact. Be an active listener. That's hard for people to do, hard for me to do. When you ask these patients, when you ask the patients or coworkers or whatever questions, give them plenty of time to respond. Nod. You maybe even summarize what they told you. Take notes so you don't have to keep asking repetitive questions. One of my pet peeves is I'll say, what's your name? And like, there's one the night before last, Armatia, something. I said, can I get your name? And she's like, Armatia, A-R-M-A-T-I. I said, pop the A-R, and then I just feel like a hobo, right? But you're going to run into that, right? Can I get your phone number? 1, 2, 3, 4, 5, 6, 7, 8, 9. Give me a second. Come on, man. But anyway, take notes, be cheerful, be smiling. I always try to talk up whoever else is going to be providing care. Like when I leave them in the ER room, even though I don't mean it most of the time, I'll say, they're going to be with you just a minute. They're going to take great care. So I try to talk up, you know.
Even though you know they're gonna be there 5 hours before someone gets there.
They'll ask me questions like, how long do you think it's gonna take? You know, I'm not sure. Hopefully it won't take too long. Hopefully, but yeah, we know it's gonna be hours. Let's see. Oh, these are negative ones. Not paying attention, leaning back, whatever. Checking your watch, looking at your phone while they're talking. Those are all bad things. Using an angry tone of voice, that's kind of crazy, but I guess that could happen. Frowning, wincing, rolling your eyes, those are all crazy. It's probably more what you see more than anything else. We're not going to do that. I say, do you see any connection between nonverbal communications and acceptance of cultural diversity?
Do you see
Any connection between nonverbal communication or acceptance of cultural diversity? I don't know about cultural diversity, but I'm sure that some people have experienced maybe when you get in an elevator, some of this. So that's a lot of nonverbal communication, or crossing the hallway to go away around somebody. You know, anytime I see anything like that, I just try to engage them. Hey, how's it going? Or I'll try to be super nice.
even during COVID, if somebody coughs?
That's true.
Yeah, I see.
That's the truth. Cover your cough.
Yeah, like I have my niece grocery store. Building. Okay, let's leave. So they like,
Yeah, you look, you wait for the podcast to come back.
Let's see, certification, you're going to get a course completion when you're done with this, but then you can go take the certification exam. And I can't remember the name of it, but it's on this book. And licensure, we're generally not licensed. The nurses are. The higher you kind of go up to medical career field, the RNs are licensed. I think there's LPNs, licensed practical nurses. And then of course, clinical experience, you're going to get that in this class. I don't know how many hours you got to do, 16 hours or something. You'll have clinical time. So there is a difference between licensure and certification. Like I'm a certified paramedic. I'm not licensed. In Tennessee, the paramedics are licensed. They're not licensed in South Carolina. So I don't know. I think that I like the idea of licensure better because you can revoke a license.
Yeah.
Right.
Can you revoke the certification? They do. The state does before you take it. But I mean, if you took a CPR class, you got certified. And American Heart Association, give me that card back.
I got anybody you have to get certified, you have to read your certification.
Yeah.
So
That's true.
I only got the third one.
The for the state, it's every 4 years. For national registry, it's every 2 years. For the paramedic. Now I don't know about the one for y'all. I can ask about it. With on the paramedic side, our recertification is really a money thing. So we have to show where we've done a certain amount of continuing education hours. Like for paramedics, it's 60 hours every 2 years. You can either do that at a monthly continuing education program or IST program, which I teach that on Shaw, or you can go to like a refresher class. So yes.
Okay, so when we finish this class, we're gonna be certified, but then we have to take a test to license. That's what I'm understanding.
I think the class gives you a course certificate, completion, certificate of completion, and then you take a certification exam.
Okay, so this is just a certificate of completion, and then you have to take your certification exam.
I
They don't license in.
I don't believe so.
Okay.
And I can't remember. It has a name. It's got a bunch of initials. They just reprinted this darn book, so I'm not sure. But it's like the International Healthcare or something. If you see it in there, it's like IHACC something certification.
So is that certification test offered here?
I'm not sure that it is through the college here, but I'm really not too sure about it.
I had mine there. This one will be here, but
I don't know where it's at. I just got these books yesterday. I read through the new print. It's chapter 2. So I'll find out what it's called. And oh, look right there, National
Healthcare Association.
Yeah, and NCCT, and I can't remember which one of these two. I think it might be this one.
That's been a competency test.
Yeah.
When I got my body, it was getting
NHA. I think that's the one that they
that's the
set you up
test.
for here.
Yeah, they pay for the first test.
Yes.
And then take a go on a proctor. And usually it's on Saturdays. So that's a good night.
Do they do them here? Like on
I took mine here.
Awesome.
Yeah, mine was here also.
On Saturday.
Excellent. I think that's the answer to
So
our
when you
question.
get you go out there and register on the website, it'll tell you what days are. Okay.
And you just like come in a room like this and someone just kind of watches.
It's one of this well, they got one down here, it's a bunch of computers. You take
Oh, okay.
and it's got the information on what it says. So what different people take.
The first one they cover, and then you can try again if you fail it, but you have to,
It's like
you have to pay for that one.
It's
Yeah.
$150. It went on. That's what it's been.
Yeah, it's expensive. If you don't get it the first time,
The first time.
the second go around, you pay for it.
I took my flight paramedic. There was a test center somewhere in Florence I went to. Similar thing where you have a computer. And they take everything out of your pockets, the locker. $385 for the test, but I found out that you knock $100 off if you're a member of the National Association of EMTs, which costs you $50. But yeah, still net say $50 off. But I know I did not want to take that test twice. Okay. Yeah. I mean, maybe you get your money back quickly if if the job pays more. So the typical requirements for the certification, you're going to complete this recognized training course, and that's where you get that course completion. And then, like we were saying, pass the exam and pay a fee. There's always that money involved. And yeah, I think those are all the things we've just been talking about. CPR, does everybody have a CPR card here? So it's cardiopulmonary resuscitation, it's chest depression, it's ventilation.
They teach that.
They do. How much do they charge you?
It's
$115?
If you're getting funding from like the continuing education, they'll pay for that. You have.
I need to raise my prices. I'm only been charged $75.
It's in the on continuing education website. Okay. And most of the one I went to was $7 Saturday. You take the class, take the test at the end of class, and then you pass, you get your certification, and then you get funded.
You can't get funded somewhere else. I would recommend you shop around.
Yeah.
I won't tell anyone to go check out Keating Regional Investment. $5. I think like Ken Hall. I think Ken Hall and Suffolk that's only charging like $30. He's not making any money at all.
Nice.
But I don't know if he's doing because I don't know if he does that because he's on the clock with Suffolk County EMS, so he can't like double dip.
Yeah.
But if you have a funding problem, I would shop around. So if you get some people, because every now and then we'll see them. You'll see them here at classes. Let's see. When you go to work for, say, the Big Mac, one of these facilities, they're going to require you to have a CPR card. The ladies that were working in that doctor's office, I don't think they were required to have it because we had this conversation with them. And then less facilities, hopefully they're going to have some type of in-service or continued education hours. A lot of it now, COVID, post-COVID is all online, like CBTs, fear-based training. So I know at least with National Registry and EMTs with us, there's no limit to distributed education. So there's no limit to the hours you can achieve by just watching videos. see. What else we got here? This is a recertification. So you have to prove that you've got the hours that you need. It says every 2 years. Yes, how often it is. So every other year. Yeah, make sure you got your continuing education hours. And really, to me, and I don't know how much it is. I think for the paramedic, it's like $55, and the EMT is like $35. So I imagine it's going to be somewhere in the $20 to $40 type range. If I had to guesstimate. The state doesn't charge us anything to recertify through the state. Let's see, you're going to work with a wide variety of healthcare providers, from doctors, cardiologists, nurses, you name it. And especially if you get into these like skilled nursing facilities and rehab facilities, you can have physical therapists. There's all kinds of people. The ambulance crews, the EMTs, paramedics. I know the young lady there mentioned registration. We used to hound registration all the time. Face sheets or information. And they used to hound us too. What's the patient's name? I don't know. All right, look at the list of common abbreviations in your QR chart printout. Oh, I didn't do a printout. How could medical terms and abbreviations like these make communication between health providers more accurate? So some of the abbreviations, I don't know if there's abbreviations in the book.
Yeah.
Excellent. So you have stuff like HTN. Is that in there? I don't know what abbreviations there.
A lot.
Yeah, I don't see it. Add that one.
PRN, short of breath. So no, it's just these are pretty common for like medical crews. HTNs for hypertension. Yeah, there's also a bunch of them that we're not supposed to use. Like we used to use MSO4 for morphine, but it looks like a lot like magnesium sulfate. So we try to. There's some of them that are on the list like don't use, but it's important that we use approved abbreviations because we don't want to mess up and hurt somebody. And I can't remember, it's somewhere around 100,000 deaths a year are attributed to medical errors. And some of those could be due to how things are coded or entered wrong into the medical. So if we're speaking to other healthcare providers, approved abbreviations is perfectly normal. And when I type out my EMS chart, it's loaded with abbreviations. I might use BBS for bilateral breath sounds. I might use COA for conscious alert oriented. You name it. There's just a long list of abbreviations we use, and that's perfectly fine. But when would you not want to use abbreviations, or who if you're talking to someone, who would you not want to use those abbreviations?
The patient.
Yeah, patient, family members. You know what I mean? Like you wouldn't want to say, "Do you have a history of DBM?" What are you talking? Tell you funny when we had you know how it is with EMS, you have to have some kind of off humor. But we had a young man who was in the parking lot. This is on the Air Force Base, and I think he was just completely inebriated, or he's barely breathing. And so he's between these two cars, this tight space, and my partner Robert Weaver, I mentioned earlier, he's trying to assess the patient, make sure he's breathing, keep his airway open. And the security forces, our cops, are standing there going, "Hey, what's his name?" Dude's name talking. Right? We're like, "We don't know." He goes, "What's his DOB?" Rob said, "If you don't leave me alone, it's going to DIE." Your chain of command, basically that's your list of authority. Everyone knows what chain of command is. The liability usually falls on the person who caused the harm, and then a policy is how things should be handled. The good thing about the way the medical stuff is stacked is the licensed people, the doctors, have the most liability, and we have the least amount. So the more patient contact you have, the more procedures you do, your liability starts to go up. That's why who has the radiology job? That's a great job because they have very little patient contact. They come in, they get the shots, their films, and the patient leaves. They make good money doing that. Where if you're a physician and you're doing a lot of patient contact, you make more money, but you have higher liability. And of course, confidentiality, we're not going to share anyone's protected health information unless it's someone that has something to do in that patient's care plan. So if it's paramedic to paramedic or paramedic to nurse or doctor, we can talk about whatever we want for that patient's care. But if someone asks me in the hallway, like, "Hey, is that a Murley over there in the room?" You can't give out anyone's confidentiality. People will try to trick you into it. Let's see. Here is a slide you probably can't read from back there. But basically, EMTs, the RNs, we're on the lower level, the lower tier. The higher you work up through here is mid-level providers and physicians. So PAs, nurse practitioners, the higher you get up in this chain, the more liability they have. And actually, where I work, I have two different chains of commands. I have a medical chain of command, and that's basically our med control physician. His call sign's Ocho. He's a pilot and a doctor. So he's a flight physician. But if I do patient contact, he is my first line supervisor when I'm providing patient contact. Then I have this administrative chain of command that is over, me showing up to work on time, in uniform, response ready, positive attitude, good communicator. So I have two different chain of commands when I'm working out there. So that could be something that you've experienced too in your career. Y'all need a break or anything? Listen, I'll just talk straight through. If you do need a break, please let me know or just use the bathroom. In the bathroom. You're not going to miss anything. If you do, it'll be on video. Let's see. Remember that policy is something that's in place. It's a course of action you should take. So we have policies, and then we have procedures. And the procedures are step-by-step how we're supposed to do something, how we actually do the hands-on part of it. All right, you're the boss. Develop a policy. We're not going to do this. Crazy. We can talk about though. Develop a policy about a topic your group was assigned. Share your policy with a group. How about you just tell me, I'll tell you my theory on policies. The worst policy you can have is one that you don't enforce, right? Yeah. So can you tell me an experience of policy y'all seen that was a bad policy because they didn't enforce?
No, you don't enforce. Yeah, there you go.
That's there you go. A lot of places I work is smoking policy. Yeah. You can't smoke on campus.
And if you smoke
yeah, listen, if you're not going to enforce the policy, it's nothing against any smokers. If there are any smokers, hey, smoke away. But it's nothing against anybody. But if you're not going to enforce that policy, you shouldn't enforce any policy. Protected health information. This is anything that can identify that person. So it could be their name, address, license plate, social security number, gym membership number. You know what I mean? Anything that could be traced back to that person is PHI, protected health information. A friend of mine's girlfriend, I was talking to my friend one night on the phone, and his girlfriend was upset, cussing about something. And I said, "What's she cussing about?" He said that she got fired. She worked at Greene County Hospital in Linton, Indiana. She got fired. I said, "What happened?" And he goes, "Well, she went up there to have labs drawn, and they didn't call her with her results. So she just logged in and checked her own labs." Yeah, you can't do that. So she was like, "Well, that's my stuff." You cannot do that. There's reasons behind these policies. I said, "So you deserve that. You do have to eat that. Don't do that. It's crazy." HIPAA stands for Health Insurance Portability and Accountability. This is like from the Clinton days, like 94 or something like that. The whole idea was to make your health records more portable with you, especially as these electronic records come along. But I'm going to tell you what, each one of these, if you have a HIPAA violation, it could be cost you $30,000 per violation. So we'll see this a lot on the ambulance, and I don't know, maybe y'all see it too. It's where we have written reports that we do. As unfortunately, not everywhere is electronic health record yet, even after all these years. And let's say I have this, like for the company I was partial owner of, these EMTs would take people to dialysis appointments, and they'll have a clipboard, and they have to get the patient signed the paperwork and stuff. Well, maybe they got late, they ran late on their dialysis appointment. Instead of them turning in the paperwork, they just put in their clipboard, put it in their car, and go home. Well, if that clipboard gets stolen, every patient that's in there could cost us $30,000 per violation. So we could monetary penalties. There could be all kind of different things. That I can't remember. We had Health and Human Services call us once. The Medicare people call us. I think they thought we had a HIPAA violation, but it wasn't us. Thank God. But yeah, look at jail time. Listen, I'm too pretty for jail. I'm too fat to run. So I tell my people, listen, I ain't going to jail for y'all. You could lose your certificate. A lot of the problem you run into with the companies like I was involved with is Medicare can actually decide to put you on a list where you can't bill Medicare. You know, most of our income was Medicare. So if you can't bill for Medicare, then you ain't going to be in business. This is just more PHI stuff. Really, it's anything that can identify that patient from their Instagram account, you name it, you cannot share it. I don't know what else we could add to that, but just anything that could identify that patient. All right, HIPAA violations may be intentional or unintentional. What are some examples of PHI that might be unintentionally compromised?
Computer leftover, somebody.
That's a good one. What if you're working on the floor and you go to take a selfie? Like, I look good in my scrubs, and there's a patient behind you, right? So you'll see a lot of these hospitals are like, they do not want your phones out, right? Anywhere near patients. Yeah. Anything else you can think of? I like the laptop. With ours, what it was a crew left a clipboard on the tailboard of the ambulance, so they drove off down Highway 15 South. Oh, wow. And then like a semi truck ran it over, and then the paperwork was just a quarter mile. Wow. So guess who was out there finding every piece of paper? Do you think that it's fair that unintentional violations carry penalties? Yeah. I think it's fair, right?
I think it's fair.
If you ever had your Social Security number lost, you think it's fair too.
It seems like this happens more and more. You know what I mean? Like you see it on the news where some company had 1 million customers. Yeah. I worked for the Department of Defense several years ago. Like all of the employees from the Department of Defense, our names were all leaked. So I guarantee you, like the Russians or the Chinese government, our adversaries, they know who I am, probably where I live. So you have to think about things like that. The high-tech one was more focused. There's another one like HIPAA that's focused on those electronic health records, the EHRs. Do you think that electronic health records make patients' PHI more or less secure?
Yes.
I mean, with hackers and everything else, right? Yeah. I guess you can make a reasonable argument. They're supposedly like encrypted and password protected. So I think the idea was that they would be more secure, but I could see where definitely could open it up. Yeah. All right. So there's these different accreditation agencies: AAA, HSI, JACO, Joint Commission, AHA. I don't think AHA really goes around. They might audit your card. Could happen. So if you take like a BLS class with me or whoever, like they could audit your card and ask you to prove that you took the class or whatever. But the big one for y'all, if you're in those big hospitals, is probably JACO. And when Joint Commission comes around, people start acting crazy. Have you ever been around for an inspection?
No.
Yeah, people start acting nuts.
Not for everybody.
JACO. I think with Shaw, we're back to JACO. We were doing AAA, HSI. We know what that stands for. But it doesn't matter. Everyone acts crazy about it, though. We have a supply room. And every time one of these come around, and I don't know if they do them every 3 years. I don't know, but they come around periodically. They'll come in there and go, we had to do something about the supply room. I'm like, no, we don't, because JACO doesn't care about the supply room. They care about patient care rooms. So they're only going to look at rooms that have something to do with patient care. They might look at our ambulance because we do patient care in the ambulance, but they're not going to look at the supply room. They will spend a month getting that supply room dialed in and like looking perfect. And every time they come around, they go, "Can you show us the ambulance?" And I'm like, "Yeah, I'm happy to show you the ambulance." And I swear to you, this is the question they asked me last time. We were in the ambulance. They said, "Y'all work 24-hour shifts?" I said, "Yes, sir, we do." They said, "Do you practice fire drills in the ambulance?" I said, "Excuse me?" They said, "Do you practice like fire drills in the ambulance?" I said, "You're asking me if I sit in the back of the ambulance and someone says there's a fire and then I escape the ambulance?" He goes, "Yeah." I said, "No, we don't do that. We don't have fire alarms in the back of the ambulance." He goes, "Well, how do you get out?" I said, "There's a door there, and there's a door there. There's no exit signs, right?" Because I said, we don't do that. That's crazy." He's like, "All right, cool." Yeah, that's it. That's the kind of crazy questions they ask. Because they're always worried about us crazy civilians working out there because like the rank thing and all that doesn't really factor into us, so we don't get crazy when there's a full bird colonel or someone comes around. We just talk to them like they're people. And the military people are like, they tighten up.
Yeah.
What's the difference between outpatient and inpatient? We're just gonna wrap it up with this.
Outpatient. The patient is in the patient in the hospital.
One is a facility, one is a doctor.
There you go. What is another general name for a medical facility where the patient might receive outpatient treatment? Let's 3 examples.
You said one, ambulatory surgery center.
I like that. Lab,
Urgent care.
X-ray, stuff like that.
Urgent care.
Yeah, urgent care would be one. My son broke his arm, so we went over here to Imaging, like across the street. Yep, those are just, you come in, you do the procedure, you leave. Day surgery stuff. There's probably an infusion center, where they do infusions. Yeah. Why is a scope of practice important for an EKG tech?
Liability, you don't want to do anything that you might be.
That's right. And if you know the scope, you can kind of, to me, it's like guardrails, right? It's a comfort thing. So it's important to know your scope, because what if they tell you, like, "Hey, I need you to go there and put a Foley catheter in real quick. Put a catheter in the penis."
Yeah.
I'd be like, "No, that's outside my scope." Right? But when I went through my paramedic course, we were at the trauma center over Columbia, and that's what they were like, "Hey, trauma patient comes in, you're going to put it in Foley." I said, "I don't think that's my scope of practice." They said, "Well, is it thing?" I said, "No problem." So when they brought dude in, I grabbed his penis and I started shoving it down as fast as I could. They said, "Hey, man, slow down." I said, "For what?" They said, "You have to stop when you meet resistance." And I was like, "Let go."
Oh. Bless his heart.
I said, anyway, they didn't ask me to do that.
I mean, that's horrible. I had to do that, so I bless that patient's heart.
Yeah. Well, he was in no shape.
Oh, he didn't
He
care.
was like, yeah, he didn't make it. Wasn't because of my phone. But they didn't think I grabbed that dude's dick. Don't dare me. Okay, so list and explain 3 types of history that are important to obtain from the patient. History, then.
Oh, history.
Heart disease, diabetes. Work, like if they work outside or they work inside, it may change their skin. However, you can puncture their skin.
Allergies, like latex allergies. Hopefully, we're wearing that.
Drug allergy.
Yeah.
Environmental.
Respiratory problems. Things that are contagious.
Yeah.
Yeah. MRSA, things like those. Yeah. I had a funny one where an EMT was asking the nurse, "This patient have MRSA?" And she said, "Honey, as far as you're concerned, everybody has MRSA." I said, "That's a good way of thinking." What is the difference between soft skills? We already talked. Give me 3 examples of soft skills and 3 examples of hard skills.
They don't work at home.
Good hygiene, right? I don't want to be around stinky people.
Thought somebody ran.
That's right. Leave. All right. What about some hard skills?
Anything that you've learned in your life, taking blood pressure, anything that you
There you There you go. Same blood pressure, pulse rate, because those are all within your scope. Checking vital signs, blood pressures, SpO2, mention the finger probe thing. You're going to do all those things. Let's see. 3 ways the EKG tech can show initiative at the workplace. Yeah, helping out other people. You see it fall. Yeah, open the door. Absolutely. And I like that too. Check on something like when I drop a patient off in the room, I usually go talk to registration and I maybe go talk to the physician if I know somebody that's there. And I like to swing by and stop by the room again and say, hey, I'm heading back out to the Air Force Base, man. I hope you get feeling better. You know what I mean? Whatever. I like to kind of follow up with them and tell them, wish them well. Good luck. Why is it important for the EKG tech to be culturally sensitive? First, it's being a good human being, right? One of the big ones I think about is when someone's anxious or stressed, it causes the heart rate to go up. It causes vasoconstriction, so the blood pressure goes up. Say again? That's right. So anxiety equals heart rate goes up, which means O2 demand, the heart goes up. So yeah, we want that nice and calm. And just, it's not cool to be a jerk. So don't be a jerk. How can a student find out about requirements for certification testing? We're going to have to ask the school. But I think she knows more than we do. So, but I can also call some former students from my last class. So, but mostly it's going to be asking Angela.
It's the NXA website.
What type of CPR certification do most healthcare providers require the EKG tech to have? I don't know if I might have blown over that. It's just the basic life support, and it'll range from infants up to adults.
Requirement, but it's like you say, it's basic.
Yeah, it's called for AHA, American Heart Association. It's just called basic life support, BLS, and that ranges from infants up to adults, and that includes AED and COPE. Their ARC is American Heart Association, or I'm sorry, American Red Cross is ARC. And I can't remember the name of theirs. It's like a CPR for the professional rescue or something fancy. They got a cool name. It's all the same. It's kids up to adults with an AED. It's children. Why should some, and there's several others. One called ASHE. There's all kinds of different ones that are approved by that the state recognizes. And I can't remember what ASHE is. American Safety Institute. I don't know what it's called. 10, why should some EKG techs be familiar with their chain of command workplace? Well, first off, for me, I like to know who's supposed to be bossing me around, right, giving me my work assignments. And if I have and listen, that happens. I'll have people tell me to do stuff, and I'll say, "Are you my supervisor?" I'm confused right now. Yeah, it's good to know because you should know who's giving you your work assignments, and also if you have a problem, right? Then you kind of know which direction you're going with it. List 2 types of penalties that healthcare facilities and healthcare workers can incur for violating HIPAA. Administrative fire, like jail time, absolutely. What did the High Tech Act of 2009 require health facilities to do? That was that electronic health records. And what's the function of Joint Commission? Scare everybody. They make sure that they're all meeting the standard. Right. All right, let's see. We're not, unless y'all want to make a skit, probably not. Let's see. What happens when the EKG tech does not use that skill? Whoa, let me back up. Soft skills. We know about soft skills. Bam, that's it for today. Nice and easy. So next class, we'll try to do, actually next class is the online class. So this is my first time doing that. Yeah. So I'm guessing what I'm going to do is I'm going to just record it like I recorded tonight and then post it on that Desire to Learn website. Yeah. Then you'll watch that. And then our next live class will be next Tuesday. And I think that's when we do, I think A&P is a heart. So anatomy, physiology of the heart. I think that's right. Yes. So the next class Thursday is going to be an online one.
Okay.
So I think what I'm gonna do is tomorrow I'll record the PowerPoint of the lecture, just like I'm doing tonight. And that'll be posted on that Desire to Learn website.
Uh-huh.
I'm not sure where, but I'm figuring it out. And if y'all just be patient, please.
We're paying.
Hang on to those.
Yeah, 60.
I can't remember the next chapter is. It might be
Basic patient skills.
say again. Yeah, I'm gonna try to have it up tomorrow. Might be tomorrow evening. But yeah, whenever you get a chance, just watch the video. And I think the initiative is just like vital signs.
Yeah.
How to take your gloves off. And then when we're back, I would prefer to do the anatomy physiology in class. So we'll try to knock out 2 chapters that day.
Okay.
And then I don't know if that's when we start using calipers, but it'll be somewhere near that next class. All right. Well, thank you guys so much. Have a Valentine's Day. It was awesome to meet you guys. Yeah, if you got those times, I'll take them up. It was the media advertising release form.
Nice meeting y'all. Y'all have a good
Thanks so much. I don't think you have to do the, I think it's called a purpose. Yeah. That way if you need next class, I'll have it. Thank you. I appreciate it. Thank you, ma'am. It's nice to meet you.
All right.
Thank you, ma'am. I appreciate that. Yeah, Thursday on lunch, you'll be back in class.
Thank you.
Yeah. Ecuador, that's awesome.
That's we go.
Think I have. No,
No, we just do this right down on the road.
just do the top part. Thank you, ma'am.
Oh.
Thank you so much. I appreciate it. You're awesome. Thank you so much. Let's stack it all together. Appreciate it.
Oh, on Tuesdays, I might be going to leak.
That's no problem.
This wouldn't be late. Cause I got on 5:15.
Okay.
Nice meeting you.
We just tell you ahead of time when we're not gonna be here on Tuesday.
Yeah, just let me know.
That's fine. I already know the time I walk.
Okay.
I have to, March the 2nd, I have to take my husband to a neurogenic bladder doctor in
Oh
Pearl.
my goodness.
Yeah,
Totally understandable.
we just gotta figure out which is the best, you know, UTIs with the straight cath and, bladder spasms with the both.
My goodness. Yes, ma'am. Y'all be safe. Thank you again. Thank you. I appreciate that.